Okay, there we go. Madam Chair, take it away.
Good afternoon, everyone, and thank you for joining us this fine Tuesday afternoon. We will go ahead and get this SURG Treatment and Recovery Subcommittee called to order. I have a time of 1:13 p.m. on June 27th in 2023. Kelly, would you call roll?
Certainly. Chelsea Cheatham.
Present.
Thank you, Chelsea. Dr. Leslie Dixon.
Present.
Thank you, Dr. Dixon. Lisa Lee.
Present.
Thank you, Chair Lee. Steve Shell notified me that he is absent. Jeffrey Iverson. Okay, Mr. Iverson may be joining us. Thereafter, we'll alert the chair should he join us. But Madam Chair, we have a quorum.
Wonderful. Okay, we'll move on to agenda item number 2, which is our public comment period. Please note that public comment will be received via the Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. If you would like to speak in public comment, please go ahead and raise your hand or somehow alert Kelly and we'll call on you.
Thank you, Madam Chair. Yes, you can unmute yourself. That's one way, or you could raise your hand. Does anybody care to make public comment? Okay. I don't see any hands raised or any persons unmuted.
Okay, well, don't fret. We have another public comment period. Thanks, everyone. Moving on to agenda item number 3. This is the review and approval of minutes from our March 20th, 2023 Treatment and Recovery Subcommittee meeting. We'll entertain a motion.
I'll move that the minutes be approved.
Thank you,
And
Dr. Dixon.
I will second.
Thank you, Chelsea. All those in favor of approval of the minutes, please signify by stating aye.
Aye.
Any opposed? And just for the record, I will abstain being as I was not present for that meeting. All right, thanks everyone. Moving on to agenda item number 4. If you'll remember, those of us who attended our meeting that wasn't, we received some lovely presentations and those were also available via video. And so we'll move to a summary and discussion of these presentation videos and recommendations. We're going to start off with the treatment and recovery for Indigenous African Americans that was presented by the founder of Black Wall Street Reno, Donald Griffin. Donald highlighted some gaps, including public engagement campaigns, billboards that focus on African American community members. He talked about the lack of programming and funding specific to organizations, reaching African American community members, and lack of opportunities for recovery and diversion and deflection from the criminal justice system. Donald brought forward several recommendations to that meeting and in the video, including prioritizing programming and funding specific to organizations that are reaching African American community members. He talked about promoting diversion and deflection programs and facilitating access to treatment specific to African American community members. He talked about, again, that bringing awareness, so campaigns, billboards, and messaging. He specifically talked about folks in the African American community that may not identify themselves as having an opioid use disorder. Lots of folks, I know Donald's talked to me a lot about it, lots of folks taking pills and don't really relate to maybe having problematic substance use. So campaigns to increase that knowledge. He talked about supporting and implementing the Track B model. And this is really related to the vending machines. Currently, Black Wall Street has a bunch of newsstands. They have a map of those locations around Reno and Sparks. But he was also interested in getting, implementing some vending machines as well, specifically in African American communities. And he talked about addressing the school to prison pipeline. Black Wall Street is doing a lot of work in the school system, doing a lot of prevention work. He also tied that prison to pipeline with the new Jim Crow, and that's related to the book by Michelle Alexander that highlights the ways in which the war on drugs has been historically upholding structural racism, and that this needs to be addressed through policy and legislation.
So, Madam Chair, Kelly Marshall, for the record, I'm not sure if you wanted to pause on the recommendations there or go on to the next presentation and then discuss recommendations.
I would love to hear what subcommittee members think about kind of the gaps that that Donald highlighted, and then the recommendations and how they intersect to maybe some of the recommendations that have been brought forward in this subcommittee. And I'll just open the floor.
All right, I'll say, first off, I have a question that has nothing to do with that, but is Assemblywoman Thomas no longer on this committee?
Madam Chair, Kelly Marshall, for the record, would you like me to respond to that question?
Yes, please, because I don't have the answer.
Okay, so Dr. Dixon, Kelly Marshall, for the record, the Attorney General going into the legislative session notified the SURG members that he would not be reappointing the legislature members until after legislative session. The SURG July meeting is the meeting that he will then reappoint Assemblywoman Thomas. They just felt that there was no way we'd be able to reach a quorum with legislators appointed to the subcommittees while legislative session was ongoing. And so that was the plan from before January. And so I believe all of the legislators will be reappointed at the July SURG meeting.
Okay. All right, thanks. All right, so it is Dr. Dixon talking. I'm confused. Putting these three words together, Indigenous African American people. I always thought Indigenous referred more to those Indians, American Indians, and African Americans were those who centuries ago, their forefathers were brought over to be slaves and then freed. Why are we putting those three words together?
Lisa Lee, for the record, I asked a very similar question, Dr. Dixon, of Mr. Griffin when he presented, and he did have something to say about that. I'm not sure that it's totally rooted in history from my understanding of it, but those are Mr. Griffin's words in the way that he worded the presentation. Does that, if anybody else wants to jump in, save me.
Elaborate if you like.
Yes, thank you.
Thank you, Madam Chair. Laura Hale, for the record. So just my recollection from doing the sort of notes from that was that he said people who come to this country without knowledge of their actual, what do I say?
Heritage or lineage.
They don't know their lineage. They only know that they were in this country. So they use that term of indigenous because they don't have their historical ancestry. They don't have a record of it. So that was his explanation of why they use that term. Does that help, Dr. Dixon?
Well, it explains what he's thinking, but I don't think it's generally known that we put those words together.
We could put it in quotations so that it's clear that this is what their reference was, or we could footnote it. These were just kind of summary notes from his presentation.
So Kelly Marshall, for the record, I would just note that as part of that May 16th presentation, the actual presentations, including questions and answers, were provided and posted for this meeting. So should any member of the public want to go back and see that, they would see Ms. Lee, our chair, asking, can you please explain indigenous? And Mr. Griffin's response to that. So I think, Dr. Dixon, you helped clarify something for the public who may have had the same question that you had.
Lisa Lee, for the record, I just want to steer us back. So semantics aside, I just wanted to kind of steer us back to a discussion on some of these recommendations. So promoting diversion and deflection, prioritizing programming, we could think of that as, broadly as BIPOC communities, engaging BIPOC communities for messaging, billboards, all of that related to substance use. Thinking about getting those vending machines or something comparable to that in BIPOC communities, and then really addressing what has been noted to be the school to prison pipeline. So thinking about those, do we have any discussion around what this body thinks about moving these recommendations forward?
I'm gonna have to excuse myself for a minute.
This is Chelsea. I definitely support all of these recommendations. I think there is a really, big importance on targeting communities of color, especially African-American communities, when we're talking about, working with people that are using opioids. I would be a little more curious to find out what Mr. Griffin thinks the diversion and deflection programs would look like. I like that recommendation. I think that would be a great one to move forward, especially facilitating access to treatment. But I would be curious to find out a little bit more about the diversion and deflection programs. And then I fully also support, the harm reduction programs and really getting harm reduction into communities of color, into African-American communities, and really working with those communities to get the vending machine programs or other harm reduction programs going.
Thank you, Chelsea. Dr. Dixon, did you have any comments related to these recommendations?
No, I mean, they all look fine as far as good recommendations. What are we supposed to do with them?
This is just open for us to discuss, and kind of if we wanted to incorporate any of them into our recommendations moving forward. All right, well, hearing no further discussion on this, I think we can come back to it at the end. We'll do a wrap up. Kind of summarizing both of these presentations that were provided. and we can come back and circle back if anything, is grabbing us, moving us to speak at a later time. We'll move on to Sean O'Donnell's presentation. Sean presented on the role and importance of peers and persons with lived experience in treatment and recovery. Sean talked about some of the barriers, including legal considerations and background requirements for peers. So there is, some that are woven into current Nevada revised statutes. And there's also sort of an additional subset of requirements depending on the agencies, which can be difficult to get around. And so one of the things I'm thinking of is the difficulty of peers in hospital settings, because there's that list of disqualifying offenses. It's also the same on the child welfare side. There's a list of disqualifying offenses to work in child welfare. And so some of those legal considerations can be really difficult, because we know people with like that lived experience are probably great, especially like thinking from my purview. And I've had lots of conversations with Sean, and I think he sort of incorporated it a little bit into this, is in child welfare. Like, we know individuals, peers with lived experience who've had that child welfare lived experience would probably be the person to talk to about reunifying with your children. But with those disqualifications, those disqualifying offenses, it really can make it difficult to hire peers in a wide variety of settings. So Sean talked about that. He also talked about sort of this diversity, equity, and inclusion for peers, and making sure that we had a really diverse peer workforce across the state, including tribal communities, LGBTQIA+, and sort of how can we create a more diverse peer workforce, including recruitment strategies, expanding education into those communities, etc. Sean also addressed better reimbursement rates for peers. To the best of my knowledge, those reimbursement rates for HOO, HOO 38 and HOO 38 HQ, those reimbursement rates haven't really increased. I believe the last time they were changed is 2006. Someone may correct me if I'm wrong. I hope I am, but I believe the last time they were amended was 2006, which is 17 years ago. So looking at how can we create better reimbursement rates for peers, and thinking about, that broad lens of utilizing peers across a variety of provider types. Next slide.
Well, this is Dr. Dixon. This reimbursement rate, I was around in 2006 when this peer thing was just getting off the ground, and they weren't being paid anything in those days. So I mean, I don't know when they even started being paid, but it certainly was after 2006, I think.
Lisa Lee, for the record, I believe that's inaccurate, because NAMS and I believe SNAMS, but I know NAMS and SNAMS, because they were part of PAN. This is way back in the day, PAN and MPLAC and all of those different things. They were peers in those settings. They were called consumer advocates, and I believe they're still called consumer advocates. And I'm not sure about the Medicaid reimbursement in those days, but I know it's been a while. And it's just a peer-to-peer, I think, is the service that is called. So in some of the recommendations that Sean mentioned, oh gosh, why are these my recommendations?
So his
Sorry.
recommendations follow. We can go to those first.
Yeah, let's go to Sean's
Right,
recommendations.
Kelly
So,
Marshall, the record.
thanks, Kelly.
I think you had discussion. It was the order of the conversation.
Okay, apologies. So Sean's recommendations were to stand up peer recovery services independently of treatment with targeted funding. So rather than be kind of under specific provider type, 14, 17, etc., sort of its own standalone service provision with targeted funding. So letting people who are directly impacted have resources to do work in the communities, thinking outside of the box, working with those who have historically been left out, thus creating a more diverse and hopefully sustainable workforce. And then supporting peer recovery support specialist training events, including train the trainer programs with technical support for other trainers. So rather than have Foundation for Recovery be sort of solely responsible for those educational programs, the 46-hour foundational education to become certified, sort of training people across the state in various communities. So thinking about tribal communities, BIPOC communities, LGBTQIA plus communities, and they are in situ of these communities training folks. So much more sustainable educational component. And then if we could go back, sorry. So what did I talk about? Oh, the START model. Yep, I already kind of touched on that. This idea of having peers working within child welfare. So in particular, we are implementing our sobriety treatment and recovery model starting July 14th. We have our peer starting, and this really pairs a caseworker with a peer recovery support specialist called a family mentor, and they work together as a dyad, working with parents with a substance use disorder that are working towards reunification. And then again, sort of looking at NRS, looking at the places in which peers might be utilized, and ensuring that there's compatibility, that there's alignment between the peer recovery support specialist legislation and other settings disqualifying offenses. So thinking about hospitals and the bridge program and peers in emergency department settings, and thinking about places like child welfare and making sure there's alignment there.
So I just wanted to note, Kelly Marshall, for the record, it appears that we are going to lose quorum in 15 minutes. And so Laura, I was just going to ask if you could once again reach out to Jeffrey and just see if he would be able to join, as Chelsea's going to need to drop off at 1:50.
I will do that.
Okay. And potentially also Steve Shell, who I believe said he could join at 2.
Okay,
To reach out and see if he could potentially join at 1:50.
okay, I will ask.
So Madam Chair, I'll turn the agenda back over to you.
Thank you, Kelly. So I just want to open it up again for discussion around some of Sean's recommendations regarding the peer workforce. So again, thinking about reimbursement rates, thinking about standalone peer services, and diversifying peers across the state, including sort of, saturating communities with the peer education by using train the trainers in a variety of communities. And I will open it up.
This is
Oh,
Chelsea.
Go ahead, Chelsea.
Oh, thank you. So I like the idea of trying to kind of increase your workforce with people from different communities. And I think we might be able to even work that into like a general recommendation similar to the one that Mr. Griffin had suggested about, funding communities or funding groups that are working with, the community that they're serving. And then would you mind also just going back so I can see the slides of the recommendation? Thank you. Thank you. No, the ones that Sean had. Thanks. All right. And then on this slide, I support both of these recommendations, and I think we might be able to find a good way to kind of move these forward, as well as the ones that you had suggested, Lisa, on the other slide.
Thank you, Chelsea. And Dr. Dixon, I believe you had some
Okay,
comments.
you just went by the one. Well, anyway,
I
yeah,
can go forward.
there we go. Stay there. Yeah. Okay, so reimbursement. Who is setting reimbursement rates and who's actually paying peers? I mean, what are we talking about?
If I may take a stab at that, Lisa Lee for the record. Medicaid does have a reimbursement rate, which is the one that I was referencing with the H0038 codes. But there's, I mean, a lot of peer work is paid through grants, which are again not a sustainable source of revenue, very short term. And so thinking about sustainability of a lot of these programs, we've got to figure out some better reimbursement rates in which organizations can continue to pay peers a livable wage. I think this is the argument for every paraprofessional, right? CHWs, prevention specialists, and definitely peers. The last thing orgs want to do is kind of dangle peers, their peer workforce at the precipice of homelessness because they're not really able to pay them enough to escape poverty themselves. So it's grant funding and Medicaid. And when the grants pull out and you lose grants, that means programs oftentimes go away.
So Kelly Marshall for the record. So I think the reimbursement, right, is Medicaid, and then funding would be through the grants, as Shirley noted. So you have almost a hybrid model where it would be, if I'm understanding the subcommittee correctly, it would be enhancing funding for peers, right, who are grant funded, and examining and increasing reimbursement rates for Medicaid, which would be a policy recommendation. So one's a funding recommendation, one's a policy recommendation, if I've got that right.
I tend to be very practical about things like this, and I think the legislature actually and the governor together with the budget are responsible for Medicaid rates. They're not very generous with Medicaid rates. We doctors haven't been able to get any kind of a significant improvement from them in all the 20 some years I've lived here and worked here. So I don't know how you're going to make the argument that they need more. Everybody needs more. And, I mean, hospitals get paid by Medicaid. I mean, and with what's happening right now, as you probably know, and Nevada's kind of taking the lead in this, is a whole lot of people are being kicked off the Medicaid rolls right now because the epidemic is over. The emergency part of the epidemic is over. And for some reason I saw in the news that Nevada is one of the states that's really jumped on this the most and has gotten the way ahead in getting these people off the rolls. So, and I think a lot of them are going to be the kind of folks we're talking about, because a lot of my patients who are substance users got on Medicaid because they, for various reasons, some because they lost their jobs during the pandemic, and others because a lot of things changed in their life, and they're going to be dropped. And so this is not and the reason being is that the federal supplements for Medicaid are drying up, and the state is having to look at how are we going to continue to pay for care for the people that are still on Medicaid. So it's, I mean, everybody should get a living wage, but a lot of people in this country don't get a living wage, including peer support people. And I'm just looking at what it would take to get this done. And would be, to me, right now, it looks like a fairly impossible situation.
So, Madam Chair, Kelly Marshall for the record. So given that we have about 6 minutes before we lose quorum, unless another one of our subcommittee members jumps on, I wondered if it would be helpful to just kind of quickly run through the rest of the slides and see if there's anything else that you would like to have a discussion about before we end, because I do think that one of our agenda items is how to present recommendations back to the SURG at the July 12th meeting. And at this point, we don't really have recommendations to present.
Okay, thank you, Kelly. So I'm assuming we can skip ahead to agenda item number 8, which is a discussion of the report out for the July SURG meeting.
Yeah, so I think, so this is Kelly Marshall for the record. So the one thing that we did have as a recommendation submitted through the spreadsheet survey was your recommendation about prevention and overdose prevention outreach to underserved communities, including BIPOC communities. And then Steve Shell had submitted a recommendation for a presentation from the Department of Veterans Services, and we do have, I'm admitting Jeffrey Iverson right now, which will sustain our quorum. So just waiting for him to come on, because then we maybe don't have to do the speed round. Welcome, Mr. Iverson.
Hi, I'm sorry to interrupt, but I'm at the NADCP conference and the time difference had me all confused, so I apologize.
We're just very happy that you were able to make it. Thank you.
Yes, thank you.
Okay, so maybe I'll abandon the speed round now that we're going to retain quorum.
That sounds great.
I would just note that we do want to sort out what recommendations, if any, and it could be that what you present, Madam Chair, is that we're shaping recommendations around peers with those specific sub-bullets noted, as well as specific outreach to the special populations noted in the SURG legislation, because that does include LGBTQ+, African-American, veterans, people of color. So I'll stop there and just turn it back over to you for discussion.
Thank you, Kelly. Yes, that is written within, what is it? AB 374. that started this whole thing. It is written within that for the special populations, but if we could go back, I didn't want to cut Dr. Dixon's discussion short because I think she brings up really valid points. And if we could just go back to kind of fleshing out some of those. I hear you, Dr. Dixon. I think you like to get enhanced reimbursement rates or to get really any kind of increase on those reimbursement rates. It's kind of like an act of Congress. I totally hear you. It is a heavy lift. Can we do it in the short term? Probably not, but the SURG is really here for those long game recommendations. The big systemic factors that impede or enhance the work that we do. And so I do feel that this is something that we should carry forward, is looking at reimbursement, higher reimbursement rates. And we can talk about, higher reimbursement rates for more than just peers, as I hear what you're saying, it's sort of across the board. But I do think that, with the SURG being kind of the long game, how can we push things through either legislatively, through the regulatory process, or policy changes or funding recommendations? I would hazard to say that it is something that we should pick up. And again, like maybe it won't go through this time or the next time or the next time, but I think tenacity will, pay off in the long run, and people will hear us. So that would be my 2 cents. And I do agree with you. It is a heavy lift.
So Madam Chair, I just wanted to note that Ms. Cheatham has dropped off, but we retain a quorum because Mr. Iverson has joined.
Great, thank you. So just Dr. Dixon and Mr. Iverson, what are your thoughts about moving forward? I don't want to cut this discussion short. Mr. Iverson, you were not present for sort of the overview of the recommendations, so I don't want to put you on the spot now, but are we good to move forward for the overview of recommendations, or do we have recommendations stemming from this that we'd like to bring forward?
This is Jeff Iverson for the record. I'm good with just moving forward. And again, I apologize for being late on the call.
No worries, life happens. Dr. Dixon, are there any of these recommendations that you would like to push forward to for this body to present at SURG? Or
Dr. Dixon, would you like me to go back to the beginning of the recommendations and take it from the top?
I keep looking at this, I'm thinking, well, these are recommendations. So there we go. That makes more, okay. I don't have any problem with any of these recommendations. I'm just, so are we trying to come up with have these for the meeting next week? Is that when this meeting is, next week?
No, Kelly, for the record, I believe it's July 12th.
In 2
and
weeks.
Really, the agenda item is a report out on recommendations. So I think it can include, we don't have recommendations to bring to you right now, but we will in October. That we're still workshopping things. We've received some presentations. We'll have more in July. That could be part of the presentation back. But we didn't want to preclude this subcommittee from having tangible recommendations if you landed on some today.
I'm just going to jump in real quick. Lisa Lee for the record. So I think going forward to, again, some of the recommendations that have been previously pushed out by this body or members of this body, I do think that there's an opportunity to weave in a few of these recommendations in a revised version of the recommendation pushed forward. Does that make sense? So I think we could incorporate elements of both Sean and Donald's presentations into, revised language of existing recommendations. That would be my pitch to workshop, maybe in a future agenda item today.
Okay, this is Jeff Iverson for the record. I have a question. I'm looking at this slide that says recommendations. Could you just quickly bring me up to speed as to what these 5 recommendations represent?
I'm sure, Lisa Lee for the record. So these recommendations, I'm assuming you watched the video of the 2 presentations from last meeting.
Yes.
The May meeting. So these are the recommendations that were brought forward by Mr. Griffin and Mr. O'Donnell. One is
Okay.
related to expanding, prioritizing programs, looking at diversion and deflection programs, engaging people with specific campaigns, standing up vending machines and accessibility to harm reduction, strategies and supplies, and addressing the school to prison pipeline, specifically related to African American communities. And then Mr. O'Donnell's recommendations were in relation to alignment, like looking at exclusionary background checks, whether that be from industries. So the examples were the hospital system and the child welfare system, specifically outlining disqualifying offenses in NRS versus sort of what's outlined in related to peer certification in NRS. And then sort of looking at, differing background requirements across agencies. So that was one of the things he talked about. He talked about reimbursement rates as being a notorious barrier. And he talked about increasing the diversity within the peer workforce. And he brought forward specific recommendations about having peer recovery support services be their standalone services not related to any sort of provider type, or they could be part of a provider type provisions of services. And then really how do we increase reimbursement rates or rethink that? And then how do we diversify the peer workforce so that tribal communities, LGBTQIA, BIPOC communities, etc., are all represented in our peer workforce. And he talked about one of the ways, one of the levers that we could use is using this train the trainer model, where they're training people within those communities to train other peers. Did I get everything? Somebody stop me.
Yeah, now I'm clear. It just I was a little bit confused when that screen popped up, having just come in and not been part of the prior discussion as to what that particular slide was. I understand now. Thank you for clarifying for me.
Yeah, no worries. Thanks. Thank you for asking.
Of course.
So Kelly Marshall, for the record, I just went back to the original recommendations. I can stay paused here or move forward to a different slide, or I can stop sharing so you can have discussion, whatever works best for you, Madam Chair.
Okay, well, I guess I'll just ask, do we have any solid recommendations to move forward, or should we move on to agenda item number 5?
Seems that's what we're on right now.
I think we're still on agenda item number 4.
Okay.
Madam Chair, Kelly Marshall, for the record, I will note that I did flash forward to agenda item 5 and then back to 4, so that might have fostered some confusion. So this is the Kelly Marshall, for the record, this is the agenda item we're on. It's a summary and discussion of presentation videos, recommendations for possible action. And
Perfect, thank you.
there's the first set of recommendations. And there's the second set of recommendations.
Lisa Lee, for the record, I believe there may be an opportunity to workshop some recommendations in the next agenda item, if we would like to carry forward anything from Sean or Donald's recommendations here and incorporate them. I believe that's my understanding. So if we're not hearing
I
any,
think that that's a good idea to move to number 5.
okay, perfect. Well, let's bring your ideas with you. We're moving on to agenda item number 5, which is the overview of recommendations received. And again, these were recommendations that were received by members of this subcommittee. And I think we can go to the next slide there. And Kelly or Laura, can you walk us through these, please?
Yes, Kelly Marshall, for the record. So just a note that we have submitted or issued to the subcommittee a survey link 3 times, asking if there were any recommendations, either for presenters or specific recommendations that the group wanted to elevate for discussion. So we've received 2 recommendations to date. One from you, Ms. Lee, which was a recommendation around prevention and overdose prevention outreach to underserved communities, including Black, Indigenous, and people of color communities. And the justification was that a recommendation from the subcommittee was to expand overdose prevention outreach to BIPOC communities. This recommendation is based on racially disproportionality in our state's overdose fatality data. So just a note that it continues to be an area of concern, but specifically for Black, Indigenous, and people of color populations. And then some presenters were suggested, and that's how we landed on Mr. Griffin's presentation. And so the recommendations you discussed under agenda item 4 came out of this recommendation. And then the second recommendation was from Steve Shell, and it was to have a presentation from the Department of Veterans Services. And the justification was that the VA provides a variety of services around the state that are pertinent to the focus on special populations, which includes veterans. So we then received that recommendation to reach out to Dr. Joseph Simpson. Mr. Shell facilitated that introduction. Mr. Simpson then identified somebody on his team to present, and that person is scheduled for the July 18th meeting of treatment and recovery, which follows the July 12th meeting of the SURG. So those are the recommendations we've received to date, in addition to the recommendations by presenters that we just reviewed under agenda item 4.
Thank you, Kelly. So members of this committee, are there recommendations from the previous, the presenters, Donald Griffin and Sean O'Donnell, that we could weave into these or add on to these recommendations received? We can also discuss sort of these recommendations as written at this time.
Well, it's Dr. Dixon, I guess to pull out of the presentation on peer support and somehow make a recommendation regarding peers. I don't know exactly what of those several recommendations I would suggest, but I do think that that's been a big issue here with us, a big concern, and so we should be recommending something regarding peers. The problem for me is it's so far removed of anything from what I do is it's real hard for me to make recommendations on things like that.
Thank you, Dr. Dixon. And I don't want to call you out, Jeffrey, but are you a peer? I'm a peer and a supervisor.
I am not, but I employ many peers. I am not though.
Okay. Thank you.
I do think that obviously it's important, so I agree with if it was Dr. Dixon. And I apologize, you guys. I'm somewhere that's kind of noisy, so I feel a little bit out of place right now with
like
my
you're on
ability to actually participate. So I apologize.
You look like you're on a roller coaster or something.
I'm in an Uber.
Oh, in an Uber.
Well,
I'm gonna
Kelly
I'll
Marshall,
turn
for
my
the
video off
record,
again.
Mr. Iverson, I will just note that we cannot hear your background noise. So
Nope.
Okay, good.
You sound great. Thank you.
Okay.
Yep. Lisa Lee, for the record, I see that prevention and overdose prevention outreach in underserved communities, including BIPOC communities, as a perfect opportunity to sort of tack on language, specifically calling out LGBTQIA plus communities. Tribal communities would be included in the Black and Indigenous and people of color communities. So I'm not sure if we need to call special attention to that, other than maybe like providing what that acronym means, I guess, in full text. And I think we could add on, this is an opportunity to add on LGBTQIA plus communities as an underserved community. It may also be an opportunity to, so I think the prevention piece is what Donald was talking about in the school to prison pipeline. So really looking at targeted prevention activities in these underserved communities. And, you know, the data supports the need for both LGBTQIA, especially LGBTQIA plus youth, and BIPOC communities. I think we definitely have data on our side that this is a huge need. And then the overdose prevention, that sort of we could weave in language around including innovative approaches to harm reduction, supply, accessibility, such as vending machines and recycled newspaper boxes. I think we could incorporate language to make that a little bit more of a broad recommendation, given that Mr. Griffin, the recommended presenter, presented on kind of the work that Black Wall Street is doing. But I don't know. It's up to you all.
Jeff Iverson, for the record, I would agree that that specific population needs a lot of help. I agree with.
Thank you, Jeff. Lisa Lee, for the record, I wanted to also just thinking about this. So we have prevention and overdose prevention outreach, but it might be another opportunity to include recovery support services, such as peer recovery support services. And we could kind of weave in peers as being an essential component of service delivery to underserved communities, with some language around increasing diversity of peers through strategies such as, and then the train the trainer recommendation that Sean brought forward. I think it's also an opportunity to address sustainability of these programs and ensure sustainability of these programs by, and then list the following strategies, whether that's ensure adequate grant funding for these priorities and special populations, and increase reimbursement rates and offer standalone service provision opportunities. I think we could weave in a lot in that one. And I'm not sure about the presentation from Nevada Department of Veteran Services, because that to me doesn't indicate a specific recommendation. The recommendation is just to have a presentation, but I'm not sure what is being recommended. Are they doing something super innovative that we want to push forward? I guess we won't know until we hear from the presenter, Dr. Simpson. But I'm not really seeing that as anything tangible that we can sink our teeth in at the moment. But I think the other one is an opportunity to sort of weave in the elements regarding peers and diversity and reimbursements and sustainability and all the things. I'd love to hear what you all have to say. I appreciate it.
So Kelly Marshall, for the record. Ms. Lee, I don't think I captured everything that you said, but I heard kind of 4 themes, which is for this subcommittee to focus on recommendations around enhancing diversity, both of people providing services, but also of specific outreach and services to special populations as noted in the SURG legislation, enhancing reimbursement for peers, ensuring sustainability, and then specifically under peer support to lift up prevention and overdose prevention outreach to underserved communities, including LGBTQIA+, youth, and Black, Indigenous, and people of color communities, including innovative approaches to harm reduction, such as vending machines, billboards, etc. Also linking in increasing the diversity of peers through that outreach, right? So, and then I think Mr. O'Donnell's recommendation included the train the trainer, then you noted ensuring adequate grant funding, increasing reimbursement rates, and then increasing standalone services. Does that, did I capture the?
Lisa Lee, for the record. Kelly, you did an amazing job of capturing that. Yes, thank you.
I was just trying to help Laura with the minutes.
Thanks.
This is Dr. Dixon. I guess when I think about a lot of these things we're talking about is, do we have an understanding of why, what's the reason that the outreach, I mean, that we need to do the outreach? What is going wrong? It sounds good. Let's improve the outreach. Let's do this, that. But what's gone wrong that it's not happening? And do we understand that?
Lisa Lee for the record. Again, there is a pretty broad corpus of data that highlight the growing disparities, especially in our fatality data. You can also look, there's some of our participants actually just put this presentation together during our community has a town hall in our program, and they put a presentation together about gender identity and sexual minorities and the relationship with substance use disorders, mental health disorders, suicidality, completed suicides, homicides, etc. And the data that they presented was pretty staggering. I'm not sure that we really collect gender identity and sexual minority or sexual orientation minority data, SURG data in our death data, but we do collect racial and ethnic data. And there's been a few papers published. Sean Thomas published a paper, what was it was it in 2022, regarding the growing Hispanic and Latina deaths, especially with young men across the state. And so we can see these disparities showing it up in our death data. That's not the place we want to see disparities, right? Because then it's too late. Our opportunity at prevention, treatment, recovery supports, outreach, that's gone because these people aren't here with us. So I think the idea is we see trends, and what are we going to do about it to ensure that we are reaching everyone. That, again, to Mr. Griffin's point in his presentation, he provided us a lot of folks in the African American community don't really see themselves in the brochures and the billboards and marketing materials that are currently out there. They don't see themselves, so they're not really recognizing, hey, that's me. I might have a substance use disorder, or I might be dependent on opioids. And so I hear him, and I think, you know, there's not only hard data, but there's also this anecdotal evidence of folks. And so anyway, I'll get off my soapbox, sorry.
Well, I mean, I agree with what you're saying. I guess, see, you know, with the medical society, we put all these resolutions together for our annual meeting, and then we are back, we get to that, and then we say, well, how are we going to implement this? And that's always the issue. How are we going to? So we say expand overdose prevention outreach to these various communities. What's the plan? What's the implementation part of it all? And that's what's going to cost money, which is presumably why these committees exist in the first place, is that there is money to be spent. But it's going from great ideas and great recommendations to planning to implementation. And I don't know. I mean, one of the problems with these various communities, which is true even of the white community, we kind of identify if it's our own group. So in other words, if we want to address, you know, people, we need the outreach people have to kind of match up with these other with these communities. It doesn't work too well if old white lady doctors go talk to a bunch of Black folks. They don't tend to take me very seriously. So I think we need a little bit more in terms of planning. I mean, implementation planning, so that we go from this step to the next step.
Thank you, Dr. Dixon. And I agree, which is why I think expanding the diversity of the workforce, especially people with lived experience. Donald Griffin is one of those people with lived experience. He is a certified peer recovery support specialist. You know, Black Wall Street started as like nothing, right? It was literally him and Romar. And they have really pulled together every resource, including donated newspaper boxes. They have carved a pathway into the schools and are working, mentoring kids at schools, and they have done all of this with a really shoestring budget. And so I think of organizations like Black Wall Street that are in the communities doing the work. And he's not alone, right? There's lots of organizations that are situated within their communities, whether that be tribal communities or the LGBTQIA communities. And so I think we have an opportunity with this recommendation to make sure that they have the workforce, the training and the resources to get the job done, right? And so I think that kind of is the implementation strategy. And I'm not sure if we're the people with the implementation pieces, or if that's when these go out to the NOFO process, to the notice of funding opportunity process, and organizations have the opportunity to apply, in which they are often asked, what is your plan for sustainability? And then, their scope of work, which kind of outlines their implementation strategy. So I'm not sure that this body would be, figuring out implementation. And correct, maybe Kelly, you can provide some insight, but I think we're more the broad recommendations for regulatory funding, legislation, those big recommendations, the boots on the ground implementation pieces, that's usually resolved elsewhere. But I do think that our recommendations should be pragmatic. I completely agree with you there. But I'm not sure we need to overthink it, because there are organizations across the state that would be happy to work within their own communities and save their friends and family members who are dying.
Well, we're gonna run out of time soon. So what are we going to do?
So Kelly Marshall, for the record, I would just confirm that, Madam Chair, your understanding that the subcommittee is to bring recommendations to the larger SURG body to go in the annual report, that those recommendations are focused on implementing evidence-based and best practice programs, addressing special populations, and with the lens for this subcommittee of treatment and recovery, right? And then policy, funding, and legislation. Like, those are kind of the categories. I would just ask Laura Hill to weigh in if I missed any of the categories of how we justified or categorized recommendations in the previous annual report.
I can't think of anything offhand, but I'll review them when I do draft the minutes and put a footnote in there so that members will have that as a reference point.
No. Thank you, Laura. So Kelly Marshall, for the record. So I do agree that you're not actually charged with saying how, you're charged with saying what and what vehicle. And so the how becomes through policy, through legislation, through funding, through new programming.
Thank you, Kelly, for the clarification. So I do want to be mindful of time. We're at 2:22-ish. Do we need to continue to workshop that recommendation? Or is it something that we could move forward with, really including, diversity of the workforce? Again, like Kelly stated, she sort of summarized that whole big amalgamation recommendation, or is that something that we should come back to in a future meeting? I think we have an opportunity to make a motion, right? We could carry it forward or not.
This is Jeff Iverson, for the record. I would recommend carrying it forward before we actually try to come up with any real recommendations.
Lisa Lee for the record. So what I'm understanding is bring this to the next meeting and workshop it, or am I misunderstanding?
Me personally, I would feel better if we were able to do that because again, and I sorry for apologizing so much, but when I step in halfway through a meeting and I have everything I have going on, I feel like I haven't been able to be present. So my initial reaction is to say, let's carry this forward to a meeting where I'm 100% present and able to actually participate. That's just my personal feelings.
Thank you, Jeff. Lisa Lee for the record. Kelly, are we able to include this on a future agenda item?
Kelly Marshall for the record. So the next surge treatment and recovery subcommittee meeting will be on July 18th at 1 o'clock. And we could bring forward, a discussion of potential recommendations around peer support, diversity of the workforce, engaging diverse communities as noted in the subpopulation sections of the SURG legislation, reimbursement and sustainability.
Thank you, Kelly. So I think it would be appropriate at this time to move forward with our agenda. Since there will be no action, we'll move on to agenda item number 6, which is presentation updates.
So, Madam Chair, Kelly Marshall for the record. So here's the list of folks that we have been instructed to reach out to. I would note that all of them except for Dr. Narizi were reached out to for this meeting as well as the July 18th meeting. From that list, Ms. Began, who is the designee for Dr. Simpson related to the VA, has confirmed her interest and is scheduled to present on behalf of the VA programming on July 18th. We have had significant challenges aligning our meetings with availability of the other speakers. We are currently now reaching out to Dr. Narizi to present on pain management. You may recall he presented at the SURG meeting, the full SURG meeting in April. And that recommendation was then workshopped and triaged to this subcommittee. So that's just the update on presentations that you have identified and what the status is of us actually confirming presenters.
Thank you, Kelly. Do we have any discussion on that?
All of them look interesting, and I would look forward to hearing from each of them if possible. Jeff Iverson.
Thanks, Jeff.
So, Madam Chair, I would just note that at the July 18th meeting, we don't have subsequent subcommittee meetings scheduled, but I believe that will be necessary to frame out recommendations to present back to the SURG. We also will likely need to weight recommendations in a similar but slightly altered approach to how we did the weighting process, but we need recommendations in order to weight recommendations. So that's why that has not happened to this point.
Great, thank you, Kelly. All right, moving on to agenda item number 7. This is the 2023 legislative session update.
So, Madam Chair, Laura Hale put this together, and Kelly Marshall for the record, I would defer to her to provide the update. There's 3 slides of updates, and I think there are some corrections or changes that we wanted to make as well.
Great, thank you, Kelly.
Thank you, Charlie. So we started with a broad listing of legislation that related to substance use, and then they get divided out by subcommittee. So in some cases, there's overlap across subcommittees. So there might be items that are listed for more than one subcommittee, or there may be some that should have been listed for multiple subcommittees. But anyway, this is kind of the latest information we have. So you can see this SB 119 was approved by the governor to expand MAT and SUD recovery support, including telehealth. And the bracketed information just tells you which sections of the legislation that created the SURG and those requirements of the SURG. That's what those bracketed items are. So this was AB 374 from the 2021 session, section 10, paragraphs E and F. And then SB 128, that one did not get passed. There was no further action allowed. The last time that was heard was in April. That was for certification of community health workers. SB 191, that has been approved by the governor, expands Medicaid coverage to behavioral analysts, assistant behavior analysts, and registered behavioral technicians for recipients under 27 years of age. So some good news there and related to some of your discussion from earlier today. And then SB 242 authorizes clinical trials with adults using MDMA or psilocybin in the treatment of mental health and other medical conditions. I believe this is also known as magic mushrooms. And that was approved by the governor. And then SB 412 offered a pathway to purchase drug checking machinery. That was corrected. There was a reference in there earlier to revising the weights for fentanyl. That one is actually SB 35. I'm not sure what happened in translation there, but in any case, SB 412 had some other things in there, but that was one of the key things, was to purchase machinery that could evaluate drug content. And
This is Dr. Dixon. Can I interrupt for a minute?
Yes.
I want to go back to SB 242. That had, we, the Psych Association, fought this one. And as did some other people, although it had a lot of positive testimony. But it was changed significantly. And the only thing really left in the bill is to create a working group to study psilocybin, nothing else.
Thank you for that update. A lot of amendments occur on these bills over time, and so they often don't end up the way that they are introduced. So thank you for that update, Dr. Dixon. So let's see, on the next page, AB 37, workforce development for behavioral healthcare, that was approved by the governor. And then AB 45. Okay, that one was specific to loan repayment. So there were several workforce related bills that were part of this session. So this one was approved as well. AB 69, loan repayment. Again, this was specific to Nevada Health Service Corps. That one did not go through. You can see that one shows no further action. And then AB 132 creates committee to review overdose fatalities, like the committee to review suicide fatalities. That one was approved by the governor. AB 137 expands confidentiality of reporting on fetal alcohol spectrum disorders, which may not be used for criminal prosecution, also approved by the governor. And it looks like Lisa has a question.
Yes, just real quick. Sorry, Laura. Lisa Lee for the record. AB 132 was significantly revised as well and did not include a committee to review overdose fatalities. It established a Clark County task force, like a work group, but it chopped out the fatality review piece.
Thank you for that update.
And then this, oh, okay, go on. I'm not sure you're gonna get to a bill I want to talk about or not. Go ahead.
AB 138, expand state plan for Medicaid to cover evidence-based behavioral health services. Any questions or comments on that one? AB 156, ensure availability of Medicaid assisted treatment in jails, detention centers, correctional facilities for people diagnosed with opioid use disorder, continuation of treatment on release or transfer. Also approved. Any questions or comments on that one?
I think, I don't know, I didn't follow very closely, but I know they didn't get everything that was original bill because corrections pushed way hard back saying there wasn't money to do it. So I'm not sure how it ended up.
Okay. Thank you, Dr. Dixon.
Uh-huh.
We will take a look at that. AB 277, Department of Health and Human Services endorsement for rural emergency hospitals to serve as crisis stabilization centers, providing behavioral health services, leveraging Medicaid payment source. That was enrolled and delivered to the governor on June 9th. I don't know if anybody has updates on those.
Mm.
On to the next one. It looks like this is the last one, AB 403, removing the requirement that such a halfway house be licensed by the division while preserving the requirement that a halfway house be certified by the division. Any updates on that one?
Lisa Lee for the record. Yes, that was amended to, so instead of halfway houses, it's my understanding that it was amended to recovery house. So this is sort of a mechanism to, from what I understand, the state is adopting NAR standards, the National, is it Association or Alliance? I never get the A right of recovery residences. And so this, I believe, was the barrier to that regulatory change through SAPTA, is my understanding. I may be not totally clear on that. So take what I'm saying with a grain of salt, but I did read through this bill and it was one of the ones I was tracking, and it amended it to recovery house. So it kind of opens up the pathway for recovery homes in the state. It, instead of being so, this was pretty prohibitive to just like re-entering folks. So that's my understanding.
Thank you, Chair Lee. Mr. Iverson, did you have a comment on that one?
Colleen Marshall for the record. I think Mr. Iverson's phone disconnected and he just reconnected.
Thank you.
So this Dr. Dixon, it's like 320 or 322, and I forget if it was started in the Senate or the Assembly. But anyway, it was the Kratom bill. And we have been fighting this issue for years. And what the Kratom industry wanted was that they get some regulation, something similar to marijuana, and make it legalized and regulated. And they moved it around from where to where, but ultimately settled on DHHS to be the regulatory commission. And I don't know how much you all know about Kratom, but Kratom is basically has many things, but it is an opiate agonist, and people can get addicted to it and they can overdose and die on it. And so we've been pushing back. We don't think it should be legalized, at least not totally, maybe move from Schedule 1 to 3 or something. But anyway, we got a lot of pushback, and we asked at least, could you put a like a disclaimer on the packaging that says that this could be habit forming and could actually result in an overdose and death, and they wouldn't even do that. Well, all of us that were opposed wrote letters to the governor, and he vetoed it. So
Well, that's good that you had some impact then.
we did. And I think he would have no matter what, because Metro was very much opposed to it. And so I don't know what they're going to do with Kratom, but at least they can't do what they were wanting to do.
Can you spell that? Is that KRATOM that you're saying?
Yeah.
Thank you. Any other questions, concerns regarding legislation?
What was the Attorney General's bill on fentanyl? Did you go over that?
That was SB 35 and Lisa, Chair Lee has that.
I was just gonna mention that. So Senate Bill 35 was vehemently opposed by a lot of folks, both on the ACRN and the SURG. And it was really amended. So it got rid of the 4 to 14 grams and it got rid of the 14 to 28 grams. So it has unfortunately mandatory minimums included in that, but it's for 28 grams and above. And those are different sort of sentencing structures. In addition, there was a MAT component for detention facilities incorporated in that bill as well. And it was passed and approved by the governor, I believe.
Yes, I think that
Marshall.
was-
Oh, sorry. Go ahead, Laura.
I was going to say, I believe we do have that listed as passed, and I think it just went under another subcommittee, Kelly.
Okay. So Kelly Marshall, for the record, just a note that I believe a debrief on the legislative session will happen at the next SURG meeting on July 12th. So it's super helpful to get clarification, and we'll clean up the recommendations or the legislative update components based on the feedback we received today. I think there's also a larger issue, which is that you see some of the recommendations were actioned through bill draft requests and then legislation, but many of them got watered down or didn't pass. And as a result, I know that there is some desire that this body, like the SURG, in July, also make a determination about what to do about recommendations that were in your report that have not yet had action. So I think that'll be a discussion item as well.
Thank you, Laura, for that presentation. That was great.
You're welcome. Thanks for everybody for keeping us up to date.
All right, moving on to agenda item number 8. It's the discussion of the report out for the July SURG meeting.
So Kelly Marshall, for the record, Madam Chair, we don't have any slides associated with this. It was really just the discussion. I wonder if based on the discussion that happened under the previously agendized items and discussed items, if we don't provide that update, I think through your Vice Chair, Steve Shell, because I believe you will not be available for the July 18th meeting. Or for the, you will actually be for the July 12th SURG meeting though. So you could do that update, and then Mr. Shell would then be asked to facilitate that discussion the next time this body meets, which was July 18th.
Thank you, Kelly. So just to clarify, the report out at the July 12th full SURG meeting would be the report out from recommendations from this particular subcommittee, of which it's my understanding that we do not have a clear recommendation to put forward. So would it be okay with everybody if I kind of note some of the challenges? Because it's summertime and there was a ledge session, and I feel like there have been numerous barriers to having quorum or getting through a meeting. And so I would just like to be honest about that, because we all are, professionals and have a lot of juggling obligations, and that we're working on it. We'll continue to workshop it. And I don't know about you all, but I feel it's important to get things right rather than get them quick.
Jeff Iverson, for the record, I completely agree. Thank you.
Awesome. Well, I look forward to thoughtful recommendations coming out of the next meeting.
Madam
Oh.
Chair, Kelly Marshall for the record, would it be helpful for me to send out the survey link again prior to the July 18th meeting, or should we wait and workshop what we've already identified today and use that for the agenda for July 18th and then send a link out?
Thank you, Kelly. I'm open to what the other members would like. My preference would be to do both. It's a yes, and please send the link again. Tailor the recommendation, the sort of compounded recommendation, including Mr. Griffin and Mr. O'Donnell's components, and send out the link again, if that's good with you, Dr. Dixon and Jeff.
Yeah, that's fine.
So Kelly
Yes,
Marshall,
please.
for the record, just to clarify, so do you want me to take the language from today and try to insert recommendations from the presenters onto that sheet, or no? I wasn't sure what you meant by Taylor.
I guess sort of my stream of conscious free flow there, where I was working on amending that one recommendation to be more inclusive of other populations and strategies, including harm reduction strategies, innovative practices, those kinds of things. You summarized it really nicely. And I'm sure
The
Laura.
prevention and overdose prevention outreach recommendation.
Yes, and then the second piece of that, including people diversifying the peer workforce by, strategies such as the train the trainer thing. I think you'd summarize that nicely. And I'm happy to, I guess, take another stab at it if you'd like me to, or if you want to bounce it back to me and tack it on. I think what you captured in this meeting would probably be the best to bring forward. Does that make sense? And then this group on the July 18th meeting can workshop that and add or subtract whatever is needed at that time. What do you all think?
I think that is a great idea.
And then whatever new recommendation, Lisa Lee for the record, with it, whatever new recommendations that come forward, utilizing that link, if you have additional things that you'd like to push forward as a recommendation, then that would be your opportunity to do that with, your materials that sort of your justification for that recommendation, and then we could workshop those.
This is Dr. Dixon. I just want to throw something out that it might influence how you write a recommendation. We are finding, and this is not true of just my company that I work for, but all the methadone clinics in Las Vegas anyway, I can't speak for Reno, our numbers of patients are way down. And we have very few new patients anymore. And of course, we have the usual turnover. So I've had days recently with just one patient or 3 patients. And so, and yet we know that the fentanyl overdoses keep going up. So there's a terrible disconnect. Some people think that part of it is because folks out there have learned how to use fentanyl or to keep them out of trouble, and there is something to that. Some of our patients have figured out how to use fentanyl safely for a time being, until I'm sure one day it's not safe. But anyway, we're not reaching the folks that need to be reached, and I have no idea if they who they are. other than the fact that fentanyl is very cheap now, compared to heroin, it's cheaper than heroin. And so when we're thinking about all these populations, we do have a terrible problem on our hands, but we're not getting them into treatment. And why is that? So it might be able to kind of do a little editing of the recommendations to, about how to reach everybody who's using fentanyl, not just some of these populations we've been talking about today.
Thank you, Dr. Dixon. I think that would be a great recommendation for you to include in that link, and summarize it. And then with any kind of justification, you even including your own data, that your population is down and that you're not doing that many intakes. I know that I talk to, our methadone clinics here quite often. And I am hearing great success about a pilot program that they've done to increase retention of fentanyl preferring new intakes, because the issue was retaining people into treatment.
Yeah, we have that problem
Because-
too, for sure.
Yeah, fentanyl is such a short-acting opioid, and because of the regulations around your initial dosing and the rate at which you can increase that dose, it just wasn't enough to retain people in treatment. So it would be, I would highly recommend having that clinic come and present kind of what their preliminary findings are. They do have some data at this time. But I think that would be a great recommendation for you to make in that survey that Kelly's going to send out, specific to fentanyl, right? Because I think that's a very specific sort of challenge right now. Great point. Thank you, Dr. Dixon.
My pleasure.
All right, we're moving on to our second public comment period. So this public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 of NRS 241.020. If you would like to speak in public comment, please unmute yourself and state your name for the record.
Madam Chair, Kelly Marshall, for the record, I don't see anybody unmuting themselves or raising their hands.
All right, hearing and seeing no public comment, we'll move on to adjourn this meeting, and we'll see you all at the big surge. I hope everyone has a great week.
Thank you, guys. I hope
Thank you,
everyone has a good
everybody.
rest of your day.
You too.